Welcome on. Thanks. Welcome on board for to this session. We are having one of our KNH-UoN webinars, and today we'll be discussing Gaucher, one of the rare diseases. And we have a host of panelists here, presenters, and we do welcome you to engage with us in our Q&A session. I'd quickly like to welcome the chair for the session. We have Roslyn Odero, who is the African Regional Manager, International Gaucher Alliance. She'll tell us more about the work they do, and she'll take us through the session and welcome our speakers. Karibuni sana. Thank you. Take it up, Roslyn.
Thank you, Agnes. It's a pleasure to be here and to join you all online on this virtual platform. My name is Roslyn Odero. I'm the Africa Regional Manager, together with a colleague called Trudy from Zimbabwe for IGA. IGA is International Gaucher Alliance, an international umbrella group representing the interests of Gaucher patients and those of not-for-profit Gaucher patient groups and rare diseases throughout the world. We are the patient-led international organization that has become the go-to global voice for over 85% of the Gaucher community. Now, locally, I'm also the co-founder for Rare Disorders Kenya, which is a patient-led organization that creates awareness and advocates for persons living with rare diseases in Kenya. Now, I'll just do a brief overview of what to expect today. We'll have the main presentation from Professor Christian Hendricks, Finding Gaucher, and then we will have a case study from Dr. Catherine Muze from Tanzania, Muhimbili National Hospital, and finally we'll end with Tanya Colin Histed as the IGA CEO to tell us a bit about what IGA does and how it supports patients and also clinicians. And then, of course, we would like to engage with you for any questions that you might have after. So at the moment, allow me to introduce Professor Christian Hendricks. Christian Hendricks is Extraordinary Professor of Pediatrics and Child Health at the Steve Biko Academic Unit, University of Pretoria, and Extraordinary Professor of Human Metabolomics, Northwest University, Potchefstroom, South Africa. He's currently employed by Nestlé Health Science as Global Clinical Development Lead for Rare Diseases, IEM, and Innovative Pharmaceuticals. He handed over his role as CEO of FIMCA, which is FYMCA, to the next generation in 2020 to continue educating clinicians on rare disease management in more than 40 countries, and the list is growing yearly. His publication list contains more than 200 peer-reviewed publications, with a majority on lysosomal storage disorders. Numerous ones related to clinical trials, quality of life, clinical guidelines, and review papers, as well as several book chapters in the field of inborn errors of metabolism. Professor Hendricks is currently online. However, due to possible network challenges, he pre-recorded his presentation, but he is online to answer any questions. And at the end, when we have question and answers, he will engage with us. So please, let's cue his presentation. Thank you.
Good afternoon. My name is Chris Hendricks, and it's my pleasure to share with you today some of my experiences with These are my disclosures. So I am not receiving any payment for this lecture, and I do this as part of my giving back to voluntary organizations, of which the IGA and also a Rare Cause are both non-profit organizations. These views I give are my own, and I do put in the publications wherever possible to try and help you. Next, there are multiple images I use, and please remember that these are restricted, so I ask people not to take screenshots or try and redo them. It is to protect our patients, and if you ever need permissions, just reach out to people, and mostly they will be able to do that. So please keep that in mind. I do have permission to use them for for this recording, but I do not have any permissions in place for anybody else to use them, and I appreciate it that you will honor this. So with much more ado, let's move on. So just a brief introduction. So I trained in South Africa originally, then I did a master's degree in sports medicine, then moved on to the UK where I did pediatrics, then I did ultra rare disease training. And then for the next 20 years, I worked in multiple rare disease centres in the UK. And ultimately, for the last 10 to 12 years, we've been working in low and middle income countries, or LMICs, where we've been training clinicians and creating awareness for rare disease and seeing how we can support the development of services. So that's just a brief intro of me. Next. But let me tell you rather more about Gaucher disease. It's a very interesting story because Philippe Gaucher, who actually described the disease, is a dermatologist, and what he really described was the changes he saw on a bone marrow aspirate, and the classical Gaucher cells is what he described. Now, he didn't do anything more, but the name was still acquired to him because it was such a great feature, and to have a new way that you could potentially diagnose these patients. So the patient on which I saw it, she had massive splenomegaly. She was a 32-year-old female. And then, of course, much later, the actual enzyme deficiency was discovered by Roscoe Brady, and which resulted in the glycolipid accumulation. It affects multiple organs. It affects bone marrow, spleen, liver, lung, and also the CNS and some of the subtypes. And I'll take you through all of these. It is an autosomal recessive condition, which means both the father and the mother should be carrying an affected gene before the patient will be affected. And once you find an affected patient, it is really important to ensure you do look for siblings which may be affected as well. So this is the classical Gaucher disease cell. Some people talk about it as a foam cell as well, and as you can see here, it's just this kind of spongy character with a cell pushed out, and this is basically all accumulation of this glycosphingolipids which are in there and pushes the cell nucleus to the end. I've already said it's a lysosomal storage disorder, which means it's one of the minor organelles, and up until a few years ago we used to she had massive splenomegaly. She was a 32-year-old female. And then, of course, much later, the actual enzyme deficiency was discovered by Roscoe Brady, and which resulted in the glycolipid accumulation. It affects multiple organs. It affects bone marrow, spleen, liver, lung, and also the CNS and some of the subtypes. And I'll take you through all of these. It is an autosomal recessive condition, which means both the father and the mother should be carrying an affected gene before the patient will be affected. And once you find an affected patient, it is really important to ensure you do look for siblings which may be affected as well. So this is the classical Gaucher disease cell. Some people talk about it as a foam cell as well, and as you can see here, it's just this kind of spongy character with a cell pushed out, and this is basically all accumulation of this glycosphingolipids which are in there and pushes the cell nucleus to the end. I've already said it's a lysosomal storage disorder, which means it's one of the minor organelles, and up until a few years ago, we used to call the lysosomes the dustbins of the cells, but we've now established that that was completely unfair because they have a very critical role. They are a form of recycling organelle, but they also interact and talk to many of the other organelles, so they are one of the control mechanisms in many of the cells. We already said that it is a defective in the beta-glucosidase enzyme, and you see this accumulation of glucose cerebrosidase. The macrophages is the main cell type which is being affected, and of course you will see the inflammatory increases due to cytokine release by these cells. These cytokines causes the cells to actually have an increased metabolic rate, and it partially contributes to why many of these patients are thin, because they're on a very high metabolic rate, so consume a lot of energy by just having this disease. So that just gives a brief introduction to the background. Next, we start looking at the mutations. So this is a really critical point, especially for clinicians in Africa, because there are multiple genetic mutations. There's about 300 to 400 already described. But it was found that the most common mutations, the N370S, the L44P, 84GG, and IVS2, are very common. And many screening programs focus only on these because that will capture about 85% of patients. However, African patients that I've been involved in, unless they are European populations like Jewish communities that's moved into Africa, but not indigenous African communities, they do not have these mutations. They tend to have a unique founder mutation, which is what we call a PT36del, so it's deletion, or also the RCN-NCIL. So these are more African mutations, and it does immediately raise the issue that if you look for gene panels, you may miss them, and is a reason why many of our patients in Africa are not being diagnosed. Like I say, there are 4 mutations which are common, and the rest are relatively less frequent and is sometimes limited to single families. The enzyme deficiency relates from mutations in different parts of the protein. You can have catalytic function, intracellular stability, or subcellular trafficking. The genotype-phenotype correlations are imperfect. That means you cannot correctly predict just from the genotype how severely the patient is going to be affected and which features they're going to have. But there are some kind of general rules that may help you, but please remember it, these are not type. They are just general ways of trying to show a better indication. It's a spectrum disorder, and what you tend to find is that the most severe end of the spectrum is usually in the youngest part of the population, and as you get older, the disease progression is actually different. The reason for that is at the severe end, at the time of birth, which you can see on the right-hand side here, you find the severe neurological phenotypes, which causes significant brain disease. And these children are usually born as hydrops fetalis, so quite swollen, edematous babies with severe brain disease who can actually die relatively quickly. Or they can have congenital ichthyosis. Ichthyosis comes from the word in Greek, which means scales. So they've got a skin that looks like scaly or fish scales, and that's part of it, but they've got the brain disease as well. And then they've got progressive neurological disease. So this is what we tend to call Gaucher type 3 disease. In between, of course, there is always a group of patients who's got some neurological disease, some visceral disease, but it's not as severe as the other ends. And then on the left-hand side, the type 1 Gaucher disease is the classical Gaucher disease, where we say there is unfortunately, they have different phenotypes of different ages, and unless you really look for them specifically, you will miss them. And here is a nice schematic to show you the heterogeneous clinical presentation. So if you're going from the top, and I'm going to start on the right-hand side, so you can find progressive neurological symptoms. Some of the classical features here is that Gaucher patients has got what we call horizontal gaze palsy, meaning they cannot move their eyes left and right on demand quickly. So they've got a stagger, and sometimes they can't move them at all. Of course, they have abnormalities of the spleen, which leads to anemia, and platelet abnormalities or thrombocytopenia. And then, of course, they've got bone involvement, and frequently this comes So let me take you through the different types just briefly. And the one thing that you can see here, that type 1, 2, and 3 Gaucher disease, they all have hepatosplenomegaly. So at least that's one thing which is constant. Bone involvement is usually absent in type 2, but present in 1 and 3. Then when you look at neurological involvement, you will find it's very severe in type 2 disease, and then in type 3 disease, it can be milder. I would most probably call that rather moderate. The eye signs are linked to the neurological disease, so you don't see it in type 1. So as well as the stridor, squint, or swallowing difficulties is linked to the neurological disease. And of course, there is additional organ involvement in all of these different disease types. But as I've already explained to you, type 3 is the kind of in-between type. Type 2 is your severe early onset one, and type 1 is the more classical Gaucher disease, which people are more likely to know about. So to make a definitive diagnosis of Gaucher disease, you really need to get a deficient level of the enzyme, which is beta-glucose cerebrosidase activity. And it's important, this should be confirmed in skin fibroblasts or in leukocytes. So that is what we call white cell enzymes. The enzyme activity in Gaucher type 1 disease ranges from 0 to about 15%. And you can do dried blood screening or DBS. I'll talk a little bit more about it, but it's really important to remember that this needs to be confirmed. A single dried blood spot is not sufficient to make the diagnosis of Gaucher disease. So the other important thing is also to remember that to look for carriers as well. Carrier testing cannot be done by the enzyme. If you want to look at carrier testing, there's two ways of doing it. If there is no concerns about the paternity, you could just do a simple graph to plan out who's likely to be carriers. But the most reliable way is actually to look at the mutations and look at the genetics. So that's to get your definitive diagnosis. So, but let's talk a little bit about a dried blood spot. So dried blood spots has become quite a useful tool for finding patients with Gaucher disease. It is an enzymatic process, which is from a dried blood spot, which is dropped onto a card. And of course, many of the drug companies involved offer this for free. And I usually say to people, if something comes for free, as long as you don't commit to support them, use them. The most important things about these dried blood spots is that firstly, the samples ideally, like the picture shows, should be dropped directly onto the blood spot card. When you take it with a syringe and then drop it on, you sometimes have contaminants in, and some of the anti-clotting factors like EDTA and heparin interfere. So ideally ask people to drop it directly on. Don't continue to drop on the finger all the time. You know, have a process where you keep dropping. Try and get one big drop, let it drop and let it soak through, and don't continue dropping on the same space, because that creates false tests as well. The other thing as well is you really have to wait for the card to dry before you put it in its special package and send it off. And when I say dry, I do not mean put it on a heater or take a hairdryer. It needs to dry at room temperature. So what we've done is we've got little trays that we use, similar to what you use for plates and dishes, and we just put the cards in there, let them dry, and then you could use them. If not, you are going to get either false positive or negative tests, depending on the handling of the samples. But do speak to your local laboratory, and they will help you to ensure that you collect the samples correctly. So, back a little bit to the mutational analysis, which I touched on previously, but it's such an important point that I just want to bring it up again. To just remember, although it said between 85 to 89% has got the common variants, this is not true for the indigenous African population. So when a gene chip is used, or gene sequencing, which is called focused sequencing, they will miss our patients. And that is, many of the patients I've seen missed in the African context is exactly because people go for genetic testing first instead of going for simple enzyme analysis, which is the best place to start in my view, especially for a clinician. Moving on, there are other complexities as well, which brings another reason in. There is also what's called a GBA pseudogene. This is a pseudogene which can look very similar to Gaucher disease, and they should not be confused with Gaucher disease mutation. So again, if you're not good with the genes and the genetics affected in Gaucher, I always say just ask the lab and speak to the experts, and please do not treat the patient who's got a pseudogene mutation because they do not have Gaucher disease. So please make sure you confirm the diagnosis. I'm going to say a few words about the other mutation just because it's important. So this gene, which is called N370S, is most probably one of the most prominent genes. It's one that's mostly seen in type 1 patients. They hardly ever have got neurological condition. And it is one that comes primarily out of the Jewish and the Jewish Ashkenazi communities. But because the community has intermarried, they come through all communities, so it's a relatively common one. The other one is the L444P. Now, when you find this mutation homozygous, which means both copies are the same, you've got type 3 disease. When you find it in combination with another mutation, it tends to have milder disease and non-neurological features. But I've said before, these correlations are not true. So don't look at the gene, look at the patient and decide if they've got neurological disease or not, rather than just trying to predict it. And then, of course, the 84GG, again, a gene which is coming from the Ashkenazi Jewish community, together with IVS2. These patients has got no enzyme activity, but tend to have type 1 disease. So again, you can't say when you've got no enzyme activity, you're going to have neurological disease. So there are caveats in here. Make sure you get the right diagnosis, get the gene.
Greetings all, apologies for that. We are getting that a majority are not able to hear clearly and also to see the audio. Rosalind, you're saying you could be able to share from your end the slides, and maybe Prof. Hendricks, in the meantime, you can just mention over what you have gone over so far.
Thank you. I've actually asked Prof. Hendricks to actually present from his side. He's currently working on that. Apologies again. It seems like there's a network issue. Prof. Prof. Hendricks?
I'm just trying to switch everything.
Sorry.
See if I can get the... Can you hear me?
Yes, we can hear you very clearly.
Let me see if I grab the switch screen. I've switched off the sound, and let me get it in presentation mode. And I really apologize for this. Oh, I can't. Trying to get the sound to switch off, which is part of the challenge. Let's see. I'll try and get you all to there. I really apologize. We were trying to stop this because of the buffering of the sound. And I think, oh, I've gone past. And if you will bear with me, there we go. So this is, I think, where I left you, just to make a quick point, and please let me know if everybody can hear me clearly now, is that basically there is a pseudogene for Gaucher disease, and sometimes people confuse that with being Gaucher disease, especially when you do mutational analysis only. So it may be the best to speak to somebody and make sure you don't treat the pseudogene patient, because that'll be the worst thing for us if we ever treat the patient who doesn't have real disease with an expensive therapy, and people will then think we are incompetent of doing that. So that is the really important message there. As we move on to the next slide. Yeah,
Professor, we are only
Yes.
seeing part of this, your slide. Maybe if you can zoom out so that we can see your whole slides. I don't know if it's only me.
Oh,
I'm able to see from my end.
The whole slide?
Yes, as it was, yeah.
Apologies. Okay, please proceed.
But maybe a request if we could go maybe from the beginning, a bit from the beginning, because we missed quite a bit.
okay, let me try and see. I wonder if there's a way. Let's see if we can just. So. I'm going to try and give you a whirlwind, but let me just see if I can maneuver the screen. Okay, can I just ask, can anybody see it? And I know it's not the ideal presentation mode, but it's one way of getting rid of the sound without losing too much time. I don't have the time to actually edit it out quickly. Is that sufficient for people to see or not?
That's okay. Please proceed.
Okay, so I will go to, I'll do a bird's eye view until we get there. So this was just to actually explain that with Gaucher disease, Gaucher was a dermatologist who actually started the whole process, and he got his name linked to a very rare disease, but actually the people who made the real difference was Roscoe Brady and people who came later, who found both the enzyme and then further described the disease in much more detail. So, but that was just the association. And then the feature that we frequently see is this Gaucher cell. Some people call this a foam cell as well. You can see it looks like it's kind of full of things, and it's actually the accumulation of the chemicals which is in there, and the nucleus is kind of pushed to the side. It is a very classical cell, but it's not typical for Gaucher only. You can see it in other conditions as well, which is one of the difficulties to make sure you do get foam cells in other conditions, and which is really why it's important to ensure we do that. So when we look at the genetic mutations, it's really important to remember that there are multiple mutations, but because 4 of them are very common, a lot of genetic testing has been done on just the 4 mutations. So you end up with people doing what's called focused screening or panel screening. And if you use that in Africa, you're going to miss your patients. And there are multiple companies, and I won't tell you their names, but there are multiple companies who actually does these screening tests for Gaucher mutations. But pardon me. These will not pick up our African patients because we have different mutations, and we also have a few founder mutations. The founder mutations are becoming more as we speak. The commonest one that we're aware of at the moment is this one, which we call a PT36del and the REC-NCIL. So those are the commonest ones, which we see in our African patients, but there is an increasing list of African mutations, and it's really important. So that's why I always say, if you're looking for Gaucher patient, you really need to be looking at the enzyme level first, and you're less likely to make many mistakes at that level. Just get you there. Then this is just to show that Gaucher disease is a spectrum disorder. The note on the right represents the 0, which is Gaucher or patients at birth. And what you find is that the very severe disease of Gaucher, which we call Gaucher type 2, is actually at the beginning end. So these children unfortunately die very early, most of them before the age of 2. And they've got hydrops fetalis. They can also have ichthyosis, which comes from the Greek word ichthos, or skins or scales. They've got scaly skin. I'll show you some images later. And they've got progressive neurological disease, and sadly, they leave us very young. Then you've got the classical type 1 disease, which is the more kind of teenage to adult disease in general. But these associations are not completely true. And then in the middle, you've got what we call type 3 disease. So these are patients which has got classical features of Gaucher, but also neurological involvement. My experience in Africa is actually quite different. I actually find my type 1 patients, so those are the ones with severe disease, but without any neurological disease from the ages of 5 and 6. So it shows you that the African mutation is quite severe, and hopefully that will alert people to not go for genetic testing straight up. So looking further, it is a highly various disorder. It's got multiple areas of involvement. I've already talked about neurological symptoms. One of the classical neurological symptoms is that these patients cannot look horizontally. So they develop something, and I'll talk a little bit more later, something called the head thrust, which unfortunately you don't see the video now, I could have shown you, but basically they shake their head to move their vision, which is they get anemia, they get bone pain, they get a big spleen, and moderate hepatomegaly. So the spleens are much bigger than what the livers are, and they can get pulmonary involvement as well. So those are the kind of different various presentations which you can find in Gaucher disease. Going into the distinctions, and this is just a table to help us get through it. So the main distinctions is that you've got type 1 disease, where you've got a big liver and spleen, bone involvement, and very little else in general, as they would say, except for the additional organs. Type 2, severe, early onset, very aggressive, and type 3, the kind of mix between the different types with both neurological disease and visceral disease. So that's the really important distinction between the types. But actually, I don't like the terminology of type 1, 2, and 3 Gaucher. I talk about Gaucher disease as a spectrum, and it is from a very severe disease to a less severe at the other end. And it gets rid of all these classifications, which was much more important. So when you look at affected individuals, you really need to remember that the gold standard for the diagnosis of Gaucher disease is actually measuring the enzyme called beta-glucocerebrosidase in white blood cells or in skin fibroblasts. We know that the activity in these tissues are less than 15% of normal. And although we use a lot of dried blood spot screening, which is a good tool for looking for patients, it is not your confirmatory diagnosis. There are ways to make sure you have to confirm the diagnosis if you get an abnormal dried blood spot, just to make sure there's not been some errors. The other thing which is important is we can't use enzyme activity for carrier testing because it doesn't truly correlate. If you want to get carrier testing, your best way is you either draw a patient family tree, and you can identify usually your people from there. Alternatively would be to do genetic testing, which really is your safest way of making sure that you catch all of your carriers. But I want to do more, so I want to talk a little bit more about dried blood spot testing, because this is something which is much more available in Africa, and there are multiple projects at the moment to try and expand the dried blood spot testing. It is a suitable method to diagnose Gaucher, but like I said, there are caveats, and we sometimes say you have to do 2 of them, or you have to have additional supporting features to make the diagnosis. It's a multiplex enzyme, and of course there are many companies actually giving these tests out for free. What I'm saying to it, we all need to remember that we are doctors and we're ethical, so as long as you don't agree to tie up into agreements that if you use their test, you're going to use their products or something like that, I don't have a problem with using the company testing. It's there to help patients, to expand the community. And that's also where the organizations like the International Gaucher Alliance comes in, supporting patients once you've got a positive DBS to see how do we make the diagnosis, what's the options, and how can we improve the life of the patient. A few words of caution. Africa is a hot continent, and you do need to get, when you do a blood spot test, the most important thing is you need to, as in the picture, drop the blood spot directly onto the card. Do not collect it into an EDTA or heparin or another tube and then spot it on the card. That causes some of the problems with the dried blood testing. You have to do it directly, and don't double spot on the card. That means you take the finger, prick it, or heel, or wherever you want to take it, wait until there is a big drop of blood and drop it on once. Don't add to that drop again. When you do multiple spottings and add additional drops on it, you actually make the test unreliable. So this is really important. The next thing is, before you send the test off, it has to dry at room temperature. So please, please do not put it in the sun or take a hairdryer or put it on the heater or something to let it dry. Just allow it to dry at room temperature. In our clinics where we've been involved in some of the LMICs, we've used things like bread racks, and you just put them in, let them stand. And at the end of the clinic, when everybody's done, they're all dry, you pack them all up and get it done. It's really, really important. Otherwise, you're going to get both false positives and negatives. I will go back a little bit to the mutations again. I've touched on this before. But just to make the point again, which is so important, you will miss the African patients. And when you find a new mutation, it's important to do additional studies to actually confirm your patient has Gaucher disease. But that is a different conversation and things, and there's help available to support you through this process. The main thing is you have to think about Gaucher, then start looking for them. And if you've got your positive test, there'll be help and support to help you to confirm your diagnosis. And you've got some very good people in the country already that can support you. Sorry for that one. This is where I left you the last time. It's important to remember there is also a pseudo gene. This is a gene that is connected to Gaucher disease. And when you look at mutation analysis only, you may potentially capture the pseudo gene, and people who's not aware of this may actually say, oh, this is a Gaucher patient, which it is not. Just always remember, you have to have 2 confirmations of a diagnosis for a rare disease patient. And if the patient does not fit the diagnosis, query the diagnosis. So just be careful that you don't call patients a disease which they don't have. It's not a service to them, and it's not a service to them. So I'm going to take you briefly through the mutations. Just the N370S is a very common mutation, usually a phenotype which is type 1, as I've said before, not always, but usually comes from a Jewish background generally. The other ones, which is L44P, this is another group of mutations that's usually supposed to have type 3 disease, especially if they're homozygous. But when they are in a compound heterozygous association, they tend to not override, meaning they tend to have less severe neurological disease. But I've said be really cautious about making these correlations. I'm talking in general to try and help you, but I would never use this because I think it doesn't really matter. Patients need to be treated adequately, irrespective of which type of Gaucher disease they have. The H4GG is also very common from the Ashkenazi Jewish population. They've got no enzyme activity and also IVS2, but again, you find that the lack of enzyme, so no enzyme activity, does not say it's particularly severe disease or involves brain. So do not use that. A few peculiar new ones that's come out. There's a cardiac variant, the D409. So this has been mostly seen in the Arab populations. And this is Gaucher disease that affects basically cardiac valves only. And we thought this was only in that part of the world, but then the Brazilians has also reported a cardiac valve. So you may find patients with cardiac valve calcifications and changes only as their Gaucher disease. How do we treat them, manage them? We don't know yet, and this is an evolving part of Gaucher disease. As you go on, you do tend to find more and more patients and learn as you go along. So moving on to the African mutation, the one which has been most frequently reported. This is a potential founder mutation. Now, people ask me, what do I mean with a founder mutation? In Africa, we don't, above the Sahara, we don't see consanguinity. That means cousins marrying each other frequently. It's quite unusual to see that. But what we find is you find a founder mutation. And a founder mutation is that people live in isolated communities, so they don't go far from where they live. And by default, they start becoming related, although they are not directly related. So what you tend to find is that the carrier frequency in the community becomes so high that it nearly has the same effect as being consanguineous. And that's a founder mutation. And we see that, and we may have seen quite a few of this in the African context. So this T36 deletion, like I say, it's usually seen as type 1 disease, and it's usually seen as homozygous, which again tells you it's likely to be a founder mutation. There's lots of the carriers around. Most of the ones I'm aware of were seen as pediatric disease and quite severe. And then the RC-NCIL has been reported in other populations as well, and is usually aggressive early onset disease. So if you put those two together, you would expect that you may find early onset severe disease in our African population, but without neurological disease or late onset neurological disease. And I think that's a reason of why some of our patients are being missed, because there are so many other things that looks the same. These are just quickly to show you that there are some what we call chemokines or biomarkers. And this we use when you find a new mutation and things. It's one of the things you could use. Your biomarkers can help you to understand, is this a real Gaucher patient? And you can also use them for your interventions. If you've got any disease modifying treatment, you could use these markers to see if they come down if you treat your patient, which can show you some idea of the response to treatment. Similarly, there is also something called chitotriosidase that's slightly more commonly available. This again correlates to some extent with the organ volumes, meaning that the bigger your spleen is, the higher the amount of chitotriosidase is. But also, if you start treating them adequately, you could get the chitotriosidases down. And we frequently use chitotriosidase and PARC as a marker to see if we're giving enough disease-modifying treatment, especially in the pediatric population, where their weights can change very quickly. But they are useful tools. But let me share with you a case from, this is from the UK, one of our patients, which I'll tell you about. So the patient was a 19-year-old fitness instructor at the local gym. It tells you already she's got normal healthy. She had a 12-month history of tiredness and menorrhagia, prolonged periods. She was getting progressively more tired, and the GP diagnosed iron deficiency anemia due to the menorrhagia. He found a hemoglobin of 9.3, and he started treating her with iron supplements. Importantly, the iron studies was not done. So ferritin and all those markers were not measured, and another just lesson. If you find patients which has got really low HBs, you have to do all the studies just to make sure you actually do have, and there's no comment that this was a microcytic anemia or anything else. Patient had borderline low platelets of about 90,000. She then presented next with epistaxis to the A&E department. Now, our A&E departments in the UK are very busy, so very quickly she had an anterior cauterization done, and they also did a full blood count. They saw a hemoglobin was 9.4, platelets was now 45,000, and they thought, this is not entirely normal, but it's not our job, so she was referred to hematology for further investigations. The patient records we looked at said there was no abnormal clinical findings, which I find really surprising. I suspect nobody really looked, and we do see that, unfortunately, sometimes as soon as you see something abnormal, the first step is to do a bone marrow aspirate. The bone marrow aspirate was non-specific, and the patient was diagnosed with ITP, idiopathic thrombocytopenia, and she was started on steroids. She had no improvements, and she had progressive fatigue, and she presented a few months later with an acute hip pain to the emergency department again. So this is a patient now who's got menorrhagia. She's already had abnormal platelets. She's had a bone marrow, is on steroids, and now she complains of hip pain. And you can see what happens in our busy lives. There's very little information from the A&E department available, but basically what they said is this is a classical young female with hip pain, and a slipped capital femoral epiphysis, SCFE, is present. This would be the classical diagnosis, and she was discharged again without much investigations, but with a follow-up in a few months. So our patient was incredibly fortunate. She returned to the orthopedics outpatients department, and here the whole story changed. She was actually seen by a medical student. So much good thing about medical students. They actually take a history, they examine patients, they do old-fashioned medicine, and this is what happened here. This medical student report, this patient has a history of anemia. She's got thrombocytopenia. He looked through the records and found that she's got a high ferritin, she's got painful hip, and she's got a large spleen. And said, to him, this sounds like malignancy. This is going to be some kind of hematological cancer, and referred to the hematology department urgently for further investigations. Again, seen by hematology, another bone marrow said nothing was found. Additional markers was done, some of the cancer genes, and was told, actually, it's not a malignancy. And fortunately for the patient, we have a rare disease center close to where she lived. And of course, when it's not malignancy, it comes to our way. And then it seems incredibly unfair, because as the patient comes to us, she's gone through multiple specialists. All the common things we know has been excluded. So we think it's most probably our diseases which are left. So we measure chitotriosidase, which was 16,000. We confirmed enzyme deficiency, and we found this is a compound heterozygous of a L44P and IVS2. So this is a classical type 1 Gaucher patient, which has taken quite a while to get through multiple specialists and things, and just to get to a diagnosis. So to put that into perspective, rather than looking at the types, let's look at Gaucher disease as a spectrum, as I've said before. So when you've got them in infancy, you can find your big spleen, your thrombocytopenia, hydrops, your ichthyosis, and seizures, because they've got neurological disease, or something called the collodion baby. These are children which are born with like a gel-like features on them, and then they peel off and they get the classical ichthyosis. So that's what is childhood. You find splenomegaly, thrombocytopenia, anemia, bone disease, and if they've got neurological involvement, you start seeing some progressive spasticity, seizures, myoclonus, stridor, and failure to thrive is classical throughout all of pediatrics. In early adulthood, you tend to find the more kind of ITP-like picture, if I can call it that, with a mild splenomegaly, thrombocytopenia, anemia. They develop gallstones because of the high cell turnover, osteopenia. And then, of course, in late adulthood, and this is late adulthood, you can find them again, similar kind of features, but now you're starting to get some of the late onset features. They have got a higher incidence of multiple myeloma, which is what they end up then, and they do get diagnosed with that and need to be monitored for that. And also some mutations, it's got a higher incidence of Parkinson's disease, but they can end up with what's more commonly called Lewy body dementia or pulmonary hypertension, and that's at the other end of the spectrum. So quite a wide spectrum of presentations for this disorder. This is just a picture to capture it, to show that if you've got anemia, you can get a cardiac murmur, you'll have a big liver and spleen, and you can have your bone crisis. And this is what we look at. So this is the collodion baby, which is dried off, and you can see the kind of scaly things here. This is just what the skin looks like, but this is what we see. Patients with really massive splenomegaly as a child already, with big abdomens. And you people will see this in many of your tropical diseases, which is why I think a lot of them are hiding in there. The bone changes is anything. This is usually older, but it can be infarction, necrosis, sclerosis, or porosis. Everything is in there. But remember, collodion skin or non-immune hydrops is not only Gaucher disease. There are other rare diseases which causes that. This is just a list of them. I'm not going to take you through them, but it's important to remember that when you see a collodion baby and it hasn't got Gaucher disease, there are other rare diseases which can cause this, unfortunately. Next thing, hepatosplenomegaly. People have tried to make life easier for our clinicians, which doesn't have a lot of access to diagnostics. And they said, if you've got hepatosplenomegaly, you just need to do a bone marrow. You look for foam cells, and then you look for corneal clouding. If they've got no clouding, it's Gaucher, Niemann-Pick, or Waldman's. And if they've got clouding, it's the other group of disorders which was on that list, which is a way to do it. But do remember, and I'll talk more about it, that actually bone marrow is not a good diagnostic tool. You will miss multiple Gaucher patients if you rely on bone marrow aspirates to try and see if a patient has got Gaucher disease. Let's focus a little bit now on the neurological disease. And I just want to show this to you. And as I've said before, it's one of the reasons I wanted the video to show it, but I'm sure you will understand my explanation. So these patients, the type 3 patients, get horizontal gaze palsy, which means they can't move their eyes all the way to the left or the right. But if you tell them to do that, what they will do is they will do a head thrust. So they'll kind of flick their head, and that will be enough to initiate their eye movements to the other side. And that was seen, and this is what's captured in our patient diary registry as well. You will also find they have an inability to look to the extreme left or right. But you have to remember there are different ways of looking at eyes. There is what's called pursuit and initiation. Pursuit means you put the pencil in front of the patient and say, follow it left and right. Now, normally you will see the eyes following. It will have a little bit of a stop, a stagger, and then it'll jump and it will move on. It won't stop. Whereas when you tell them, yes, at the pen, look to the left, left to the right, you will actually see the eye physically stopping, and then you'll see the little head thrust. So it's an important way if you start looking for type 3 disease. When you're looking for other features, the common things you tend to find is muscle weakness, and of course, tremor when they are reaching out. Going on, hematological parameters, you've heard me saying so many times already, thrombocytopenia, anemia, hyperferritinemia, chitotriosidase, if it is available, it's an important thing. But what I want to do is I want to focus on my next slide, which is the common misdiagnoses. Now, people in Africa are very good with tropical splenomegaly, as well as sickle cell, spherocytosis, and those. And these are frequent. Sorry, is there a question there? Oh, okay. I hope everybody can hear me. I had something coming in. So if you've got in your part of the world, or malaria will be another one which people will say this is the cause for it. But you have to look at the other things. And I know HIV, TB, leishmaniasis, there are many things that will cause it and looks like it. But as long as you remember, do not do a bone marrow aspirate to look for the diagnosis, because there's been a good study done to show that only about 28% of the bone marrow will have foam cells in it. So unless you're lucky to get a specific area of the bone marrow, or you've got somebody really experienced, you will miss it. The other problem we find is that when people are looking for foam cells, they tend to look on a high power on the microscope, and you will miss them because the cells are so scattered wide apart. You will miss them. The real clue is, if you're looking for foam cells, tell your pathologist you need to look at a low magnification, because you can then see at least a bigger part. Now, although I've said I don't like bone marrow aspirates, if you've got nothing else, use it, but try and get something else, is my advice, because I think you are just missing too many of our patients, and that's the really important thing. So next is, how do we manage our patients? Now, there was a committee set up, and experts came together, and they said, if we're going to be managing patients, the things that we critical to patients is we've got to decrease the liver volume, we've got to get the spleen volume down, we've got to get the skeletal disease under control, we've got to get the bone crisis and pain away, control thrombocytopenia, we have to normalize the growth, we have to stop further complications. This is a really nice paper to look at it, but I want to give you a perspective of how it plays out in real life. If you look at the overall systems monitoring, people say to me, but we in Africa, we can't monitor these patients. And I say to you, no, you can. And please don't ever tell me that again, because we talk about hematological. Everybody can do a full blood count, white cell count, and iron. That's relatively simple. You can do that, and at least hemoglobin and platelets will tell you if your patient is getting better or not. I don't have access to MRI and thing for livers and spleen. No, you have. You have your hands, you've got a tape measure, old-fashioned medicine, costal margin, make the mark, measure it, spleen size, 15 centimeters in the direction and umbilicus, record it well, and if you've got a patient on treatment the next time, you will know if it's getting better or not. So there are ways to do it even in that way. Other things as well as x-rays is not ideal, but they're better than nothing. You can look at x-rays of the femurs and the spine, which is the best areas. Echo, fortunately, is becoming very common and freely available, so you can do that. And of course, there's always physical examination, and then there is also quality of life tools. And I would encourage you to use them. And at the end of my presentation, I've got a few examples of tools which you could very easily adapt to your local practice. And that will give you a really good way of following up and see, is my patient really getting better or not at all? So, is my patient getting better? As the clinician, I would say, is the hemoglobin getting better? Is the platelet numbers? What's happening to chitotriosidase, PARC, and ACE? Is the amount of bone crises getting less? If patients got seizures, are they decreasing? What happens to the liver and the spleen volumes? What happens to the bone MRI? But our patients are not interested in that at all. Our patients are just interested, will I have less fatigue? Will I have less episodes of bleeding? Is my menorrhagia going to get better? Will I have less epistaxis or nosebleeds? Will I have less bruising, that it doesn't always look that I have to cover up my arms and legs because of the bruises? Will I need less admissions because of bone pain? Will I need less opiates to use for the pain? Can I do more stuff because my disease is stopping me things which are important? And how can I be more normal in society? I want to go to work. I want to have an education. I want to have a social life. But if I've got a tummy which is standing out there and I'm 16 years old, I can't fit in any of the dresses or anything that makes me stand out. So I'm never going to fit into society. How can you make me fit into society and make my quality of life actually better? So I've already talked about what can be used, and I'm not going to go through them again. This is just for completeness. But let's touch on potential therapies. And this is another one of the things that makes me really cross. When people say to me, I don't look for Gaucher patients because I can do nothing for them. My first question is, if you say that, you should not be a doctor. You've become a doctor to be empathetic to your patient. And even if you can do nothing, you really have nothing, you still have to find the diagnosis, you still have to put them in contact with the patient groups, you still have to support them and be there to help them, and you have to give them hope that sometimes things will change. But there are simple things you can do for these patients. You can improve their vitamin D status. Many of them have got bone health issues, so they need additional vitamin D. Their tiredness is also linked to vitamin B12 deficiency, so you can give them vitamin B12. If they've got severe fatigue and very low HBs, you can do a transfusion to get the hemoglobin up and get their fatigue a little bit better. Now, I know blood transfusion comes with many other issues. You have to use desferrioxamine and all of the things, and you will know that very well and the complications around that. But it is something that you can do potentially at a special occasion. And I've said to somebody, why can't you infuse the Gaucher mother before a daughter's wedding for a once-off or something? Think about your patient, how you can make their lives better. Platelet transfusion before doing some procedures, or simple methods to look at things like tranexamic acid to try and reduce menorrhagia. Our surgeons are always keen when you've got these problems to say, just take the spleen out. And I would ask you, please, if you can, encourage the surgeons not to take the whole spleen out. If you end up with doing splenectomy, try and do partial splenectomy. The main reason for this is that I know it's complicated, but the problem is that in Gaucher disease, the spleen acts like a sponge for Gaucher cells. And the moment you take the whole spleen out, the cells go to the organs which they normally don't go to. So your bone disease gets more and your lung disease gets more. So if you can leave part of a spleen, it's much better. And if at all possible, do partial. You could also use bisphosphonates to improve the bone pain by your patients. And of course, if the Gaucher disease has destroyed a whole joint, you could always do a joint replacement. So there are much things that you can do for your patient. I'm not going to spend a lot of time on the disease-modifying therapies, but I want you to be aware of them. You can make a case in saying that actually a bone marrow transplant is a treatment option for Gaucher disease. It's a once-off cost. You get good symptomatic relief. Bone response is variable, but you have to know there are significant morbidity and mortality negative effects. So in our part of the developed world, it's actually unethical at the moment to do bone marrow transplantation because there are better options available which can be used. There's also not a lot of information on graft versus host disease at the moment available, so we don't know. And then, of course, we know your mortality with bone marrow transplant increases with age. It also depends on geography and it depends on matching. So you tend to find with geography, you find poor matching and poor suppression therapies. So my experience actually is that bone marrow transplantation in LMICs actually should not be done at all either, because the expertise and the additional support is not there and it doesn't solve the problem long term, and there are better options available. But I accept that in some parts of the world, this may be the only option, and you've heard me many times before, only options are better than no options, and we need to do best for patients, but we do need to make them aware of what all the risks are. Enzyme replacement therapies, there are multiple, but in essence, these are intravenous therapies. They are given different schedules, but mostly every 2 weeks or sometimes even later. They are variable dosing. You need to change them according to children's weight. And I'm not going to be focusing on the treatment modalities. I just want to make you aware of them. They are very efficient. Infusion-related reactions are minimal, and we don't have as many as with some of our other products. The biggest concerns with these are practical is venous access, and then more practical is actually this is lifelong therapy, and it is costly for many people. However, there are solutions, and I think rather than focusing on the cost, we need to find the patients and then start finding the solutions. And again, this is where the patient organizations can support you. To be fair as well, there are also what's called substrate reduction therapies. This works on a different mechanism. Enzyme replacement therapy means you give you the abnormal enzyme and it does the trick. Substrate reduction therapy means we decrease the amount of chemical which is accumulating, so we're slowing down the disease process. Now, depending on which part of the world you are, there are either 2 licensed products or none, and there's quite others in the pipeline, but I think it's really important. So these are oral treatments, so they will be easier to get to remote places. You don't have the access problems and things, but they also come, oral treatments needs to be daily, and they come with side effects. And a very interesting observation through the years I've had is, for some reason, people are much more likely to stick to a 2-weekly IV treatment than a daily oral treatment. And I'm not entirely sure why. I think it's just the benefit potentially is quicker. What you tend to find is that when you take a IV therapy, patients start feeling better relatively quickly, whereas for the substrate reduction therapies, it takes longer, so they actually lose faith in it because they don't continue long enough. So I think those are just some simple thoughts. Other things, there are lots of promising therapies in development. Gene therapy trials has got some very promising data for Gaucher disease at the moment. They will be potentially one-off therapies. At the moment, they look like they will come at a huge cost, but of course, costs will come down and there may be ways to manage this. The other things is we see reduced mitochondrial function in our patients. So there's some people saying maybe Q10 can be used, and there's multiple other things looking at the other causes and the other reasons for patients not being well. But I think these are all development. There's a lot of research, but the things I want to leave you with is just to say, this is the commonest of the lysosomal storage disorders. There are multiple of these disorders in your communities, and I hope we can get Kandi Muse's presentation to run as well, that she can tell you her experience. I will say up front, if for some reason it doesn't run or we have the same kind of issues, I will try my best to do her presentation on her but I don't have access to it at the moment, but I'm sure it will be somewhere where we can get hold of it. So that is the end of what I want to leave you with, and I just want to really quickly show you there is resources that you could use for your patients. This is the DS3 scale, which just look at different scores, and this is what it looks like for a patient. So you can see how severe is the disease, and you only do the bits that you have. You could also use a fatigue severity scale to see how tired your patient is, or you could use something like the EQ5, D5L, which is a simple scale. This is not a huge and impressive scales, but they are much better than doing nothing. And that's always my argument. Please do not tell me because I'm in an LMIC, I can do nothing. Get your patients, help them, support them, and get them connected to the patient groups. I'm going to stop there, and then hopefully the rest of the presentations can carry on. Thank you for your time, and sorry for the technical difficulties at the beginning.
Thank you so much, Professor Hendricks, for that presentation. Next, we'll move to pre-recording. I hope we will not have some of the challenges that we had by Dr. Candy Catherine Muze. She's a pediatrician and a pediatric endocrinologist. Currently, she's the head of pediatric endocrinology unit in Muhimbili National Hospital in Dar es Salaam, Tanzania, the largest referral hospital in the country. She pursued her fellowship in pediatric endocrinology from the Pediatric Endocrinology Training Center for Africa, PETCA, program based in Nairobi, Kenya, in 2009. She's also involved in teaching pediatric postgraduate and undergraduate students. Apart from the interest in various pediatric endocrinology issues, she has interest in inborn errors of metabolism, especially in Gaucher disease. She's currently not online, but she had a pre-recorded presentation. Agnes, please cue that in.
My name is Candy Catherine Muze. I'm a pediatric endocrinologist from Muhimbili National Hospital, which is in Dar es Salaam, Tanzania. And I would like to thank the organizers for giving me this opportunity of sharing with you a case of Gaucher's disease, which is the child I'm presenting is GGM, who is 15 years old now. He's a male, and the informant was the mother. This child was seen first, it was about 9 years ago. By then the child was 6 years of age. The child presented with abdominal swelling, which was noted when he was 5 years. And this swelling was gradually increasing in size. It was also associated with cough. By then there was no difficulty in breathing. And occasionally he presented with night sweats. There was also loss of weight. However, there was no history of any TB contact. There is no history of jaundice. There was no bleeding. By then, there was no any bleeding from any sites, and there was no bone pains. The first visit was found to have an enlarged liver of about 14 centimeters and splenomegaly of 8 centimeters. So he was suspected to have chronic myeloid leukemia. That was the first differential diagnosis which was thought. But then they thought maybe it could be sickle cell anemia, because in our area, sickle cell disease is a very common condition. They also thought maybe it could be lymphoma, or it could be abdominal tuberculosis. But then the first doctor was also thinking it could be one of lysosomal storage disease. And the doctor thought it could be either Gaucher's disease or Niemann-Pick disease. The child had undergone extensive investigations, but for the sake of this presentation, I'll just give a summary. Some of the label investigations were done, including full body picture, HB electrophoresis, chest X-ray, echocardiogram. They were all unremarkable. But abdominal ultrasound and CT scan, of course, they revealed hepatosplenomegaly. However, there was no ascites. What they found that there was multiple lymph nodes. So with these multiple lymph nodes, and because no any other lab tests were positive, they thought maybe we are dealing with extrapulmonary tuberculosis. So the child was started on anti-TB, which were then by a combination of rimactazid, pyrazinamide, and ethambutol. So by then, we didn't have any means of excluding lysosomal storage disease. So the child was kept on those anti-tuberculosis for almost 9 months. The child was readmitted in 2017 when he was 10 years of age. There was progressive abdominal distension, and now there was nose bleeding. The good thing, there was no bleeding from any other side. On clinical examination, it was found that the liver was increasing in size. By now it was 16 centimeters. And the spleen, you remember the first time it was 8 centimeters, now it was 14 centimeters. And full blood picture started to show pancytopenia with the hemoglobin of 9.9, which was not so bad, gram per deciliter. And the WBC was 3.7. There was obvious thrombocytopenia of 77.2. Requested surgeon to review, and the surgeon thought maybe there are 3 possibilities. It's either portal hypertension, lymphoma, or glycogen storage disease. So they ordered a OGD, which was done and it was normal, and they also liver biopsy, histology. So pathologists reported that there were features of glycogen storage disease type 1. So the child was cancelled on the diagnosis of glycogen storage disease type 1. The child was readmitted for the 3rd time now in 2020. He was 13 years of age by then, and there was still progressive abdominal distension, bleeding from the nose, and also now he started also passing blood in stool, and there was swelling of both lower limbs. On physical examination, the child was full conscious, febrile, but there was severely wasting. He was moderate pale. There was no jaundice. Peripheral lymph nodes were not palpable. Weight was 35 kilograms and height was 129 centimeters. The abdomen was grossly distended, and there was visible distended veins. We saw huge hepatosplenomegaly with the liver size of 24 and the spleen size was 27 centimeters below the left costal margin. The CT scan, of course, revealed there was hepatosplenomegaly, and it was reported that there was no. We repeated the full blood picture, which showed pancytopenia still, and with a hemoglobin of 8.05, and it was decreasing more from 9.9. MCV and FCH showed hypochromic microcytic anemia, and the white blood count was very low, which was 2.02, and absolute neutrophil count of 1.14. The platelet was very low, 53.1, which is thrombocytopenia, and iron was normal level, but ferritin was 382.7. This is higher than normal, and in Gaucher disease, most of the time you can find ferritin is increased. This is a very good marker. Also can be used for monitoring of the disease, and also during treatment. If ferritin is high, when you start treatment, you can find ferritin is also becoming normal level. Liver enzymes, creatinine and urea were all normal, and we had a chance of doing genetic testing. By that time, we had a collaboration with Centogen Lab, which were taking dried blood sample to them free of charge, doing the test free of charge. We thank the FIMCA because they introduced this opportunity when we went to the meeting in South Africa. So from then we had a chance of doing this DBS free of charge. The genetic test results came back after about a month, and it revealed a homozygous pathogenic variant which was identified in lyso-GB1 with concentration of one of the very important biomarker, lyso-GB1, which was increased so much, and the activity of the important enzyme in Gaucher disease is a beta glucose cerebrosidase. This one was found much lower, and this had confirmed that we are dealing with Gaucher disease. When we see the actual level of beta glucocerebrosidase enzyme, we find that it was 1.61, and this is very much reduced because the normal level should actually be more than 4.1. And the lyso-GB1, which we said it is a very important marker, was very high. It was 777 nanogram per mil, and usually this one should be less than 6.8. And if we see here the amino acid change, I don't know if it's clear, but this GBA variant has been reported in many other studies as a cause of Gaucher disease. So we have confirmed it by enzyme levels, by the markers, and also by doing the genetic test to find an abnormal variant, which is very important in Gaucher disease. So our patients have been confirmed to have Gaucher. After confirming diagnosis, the child was started on enzyme replacement therapy, and we are lucky that we got a donation from Direct Relief, and the child started his first dose on the February 2021. It's now like 1 year and 6 months, and the child has shown remarkable improvement. The weight has increased to 37.5. The height is growing now it's 139.5, and he's receiving the dose of 60 units per kilogram per dose. Usually it's 2 weekly. The Direct Relief also support the transport funds to a nearby hospital. It's not necessary the child should travel all the way to Dar es Salaam, so we usually arrange with a nearby hospital to provide this medication. And also we are thankful to the Direct Relief because they also support children with health insurance. Now the child is in secondary school, is a Form 2 student, and fortunately he has not experienced any drug reaction so far. Yeah, now let me share you about Gaucher disease in Tanzania, the story on the Gaucher disease in our country. We tried to find if there is any case report, and we didn't find any current Gaucher disease. Maybe this is the cases where we'll publish, but the recent one was 1977 July. It's a very long time ago. But now we are happy that children with Gaucher disease do not have to undergo splenectomy anymore. You can appreciate this child had a very huge spleen and liver. It was so tempting to say, can we remove it? But now we have treatment, we have enzyme replacement therapy. We don't need to do splenectomy again. So after diagnosis, we just start the medication, and the improvement is usually progressive, and you find after some time children don't have any more palpable liver or spleen. So we are lucky that we have a Direct Relief helping us, as I've said before. They help us with the transportation of the infusion, and also health insurance coverage costs, and also transportation of the patient to a nearby hospital. In Tanzania, we have managed to test 48 children for the last 4 years. That was between 2018 to 2022. And among these 48 children, 16 of them became positive for Gaucher disease, and 31 was negative. And we are waiting results of one child. We have not yet got the results. So among these 16, 9 of them we've managed to put on enzyme replacement therapy. And up to now, we are waiting for approval of one child. And unfortunately, despite having these good stories, we had lost 6 children. One of them had started enzyme replacement therapy, but along the line, he was lost to follow-up, only to get information that he died of pneumonia. And we are suspecting maybe it was because of COVID, because it was during the time when we had a very high prevalence of COVID in our country. And among those also we had 2 who had excessive bleeding. One was from splenectomy and another one was after doing bone marrow, had excessive bleeding. And this usually happens because in our hospital, we receive these children already in a very advanced stage. And most of them, they are very sick, very low hemoglobin. So it was unfortunate that we lost these 2 children. And two of them had severe anemia before initiation of enzyme replacement therapy at home. That was while they were waiting for results and also waiting for medication. One child also died after complication post-splenectomy, and this had a severe infection after surgery. He had died in ICU in our hospital. So far, those 9 children, they are still doing very well. They are in enzyme replacement therapy. So what have we learned from this practice for these 4 years? We think that there's a possibility that we're missing a lot of now. I mean, quite a number of children with Gaucher disease, just because we don't have genetic testing, we don't have means to test enzyme level, and as such, we find children coming to our hospital very late. And also, we found that there's a lot of advantage of having collaboration with other, maybe well-equipped centers, at least for diagnosis and treatment. And also, we think that pediatrician really needs to be reminded that, and all this maybe education now and then, to remind ourselves that Gaucher disease, of course, should be one of the differential, especially when a child is presenting with a massive splenomegaly, and maybe you have ruled out that this is not sickle cell, this is not any hematological malignance. One of the things which should come first in our mind should be Gaucher disease. So before I wind up, maybe I would like to share with you what other rare diseases we've been able to diagnose by genetic studies. And among these, we've been able to diagnose galactosemia, Pompe's disease, factor 10 deficiency disorders, factor 7 deficient disorders, which these children, we were just thinking maybe it's hemophilia A or B, but we find that there was no improvement. But when we did these genetic studies, we found there are those rare factor deficiencies which we didn't know before that they exist even. So we had been able to diagnose factor 10 deficiency in 2 siblings. And of course, factor 7, as I've said, CAH, which most of them, they have 21, hydroxylase deficiency. We have diagnosed Lowe syndrome, mucopolysaccharidosis. We diagnosed mucopolysaccharidosis type 2. We've been able to pick Niemann-Pick disease, Wiscon-Aldrich syndrome, and so many other neuromuscular disorders, including spinal muscular atrophy, muscular dystrophies. And we really think that we need to build up our capacity in African countries, because people maybe were thinking these diseases are not existing in Africa, but it's only because we didn't have the capacity of testing these rare diseases. And due to high cost of these tests, because they are really expensive, consideration of subsidizing the price to underdeveloped countries in Africa is highly called for. With this short case presentation, I would like to say thank you for this opportunity and also thank you for listening. I'll welcome if there's any question or clarification.
I'd like to thank Dr. Kandi Muze for that presentation and for her time to create awareness about Gaucher and sharing that case study. Next up is Tanya Colin Histed. She's the CEO of International Gaucher Alliance, IGA, and has been advocating for patients' rights for 25 years now, as she believes everyone deserves an early diagnosis, treatment, and best possible care. She's also a mother of a Gaucher type 3 daughter. Tanya, please present your slides, or can we go ahead and Agnes, do you think we can use her presentation now that it's clear? Agnes?
Yes, we are checking that. Just a moment.
Okay.
Actually, if Tanak is able to do it from my end, it would be better.
Okay. Tanya, will you be able to present from your end?
Yeah, I will certainly. I'll certainly try. Can you see my slides?
No, we can't see.
What can you see?
All the panelists, have you shared it?
Yeah, I did share it. Let me just try again. Can you see? What can you see now?
I don't see it on my end. Agnes, can you see it on your end? It's my end.
No, we can't see it on our end. Okay, I think it has started sharing.
Okay. Can you see it now?
Yes,
there we go.
can.
Yes.
Perfect. Apologize. Okay. So thank you very much for the invitation today, and just to say that I have thoroughly enjoyed the two previous presentations. As Rosalind said, my name is Tanya Colin Histed, and I am the mum of Maddie. And I am the mum of Maddie, who was diagnosed with type 3 Gaucher's disease. And like many rare disease advocates, my background was really becoming a parent and really wanting to strive for information and make sure my daughter had the best life that she could have. So today I'm the CEO of the International Gaucher Alliance, and I'm going to spend just a few minutes so that everybody can have some questions talking to you about the work of the IGA. These are my disclosures. So the IGA was started in 1994 actually, and it used to be the EGA. So we used to be a European focused organization. But more and more of our members and patients around the world from outside of Europe came to us to ask for support and information. So in 2018, we became the International Gaucher Alliance, and we now represent 57 countries who are our members from around the world. But what's more important, particularly for today's session, is that we're actually working in 20 other countries, many of them in Africa, supporting people like Rosalind and Trudy to improve patients' lives, and also individual patients that have reached out to us. One of the challenges that we have as a rare disease organisation is that we have very limited resources. So apart from myself and a small team, everybody who works for the international organisation are actually volunteers. And many of these are parents and also patients who want to give back to the community. So although we have a very challenging, a very wide membership, we're aware that there are still many countries around the world where we have little or no information on patients. And you can see from this slide, the little balloons are where we have members, and the arrows are where we know that there are patients and that we are working really hard to try and find out information in these countries. And the way that we have done this is that 2 years ago, we decided to set up a new program that we called our Regional Manager Program. And we wanted this program to really be the eyes and ears of our organization in countries where there wasn't an established patient organization. And we wanted them to collect information so that we could build up a picture, so we could really understand the lives of Gaucher patients in those countries, and also the challenges doctors were having and how we as an organisation could support them. However, as I've already said, we really do have limited resources, so we needed to decide who were going to be our regional managers. We decided that we would look for volunteers as a mostly volunteer organisation. And we were really lucky that we had a lot of people who wanted to support us. I've got to say that some of our regional managers are actually young Gaucher patients who have received treatment through charitable programs, just like we heard about the young boy in Tanzania. These Gaucher patients are now young adults doing really well because they received treatment and they want to give something back to the community. And then we've got other volunteers like Rosalind and Trudy who really want to make a difference in the communities and the countries that they are working in. The IGA have a huge volunteer program, including the Regional Manager program, and we do provide support with training and education to these people. So we have a number of different programs. And the one that I want to highlight to you is our number 6, which is really around the African region. And you'll see here the countries that is in this program currently, and we hope to extend it. And we're obviously delighted that Rosalind and Trudy are playing a huge leading role in that work in our regional program. So Chris Hendricks talked a little bit about this in terms of the challenges in Gaucher's disease. Now, this is where we see the work of the international organisation as so important, because collaboration is the key to everything. Through collaborating, we can hopefully improve education, we can improve access to diagnostic facilities, we can bring people like Chris Hendricks to sessions like this who to really give an experienced view of treating these rare diseases, but treating them often in countries where there are a lot of challenges. So I'm from the UK, and I know that we are extremely lucky here. We have had access to treatment for our patients for many years, but in so many countries around the world, that just isn't the case. And you can see this picture of this young boy in Pakistan who didn't get access to treatment and sadly passed away. And as we've seen from the last presenter, but also we still are seeing patients pass away with Gaucher's disease every day. And it's only by working in collaboration that we hope that we can improve education, awareness, access to treatment, and access to diagnostics. So as an organisation, we see that the International Gaucher Alliance are really the global voice of the patient community. And our role we see is to empower patients and patient advocates to work in their own country, to develop education and awareness. We advocate to identify areas of research that need still to be done, and really where there are huge unmet needs. Particularly if you look at Gaucher's disease in the neuronopathic patients, at the moment there is no treatment that crosses the blood-brain barrier. We also are really here to take collective action to address a lot of the things that have been talked about today around diagnostics, optimal treatment and care. One of the things I want to mention that I've highlighted on this slide is that at the centre of everything we do is the Gaucher patient. I've also highlighted the humanitarian aid programme. As an organisation, we do work with companies like Sanofi and Takeda and Pfizer, who manufacture treatments like enzyme replacement therapy for Gaucher's disease. As part of their corporate social responsibility, they do have charitable programmes. Now, what we do is we work with them and we make sure that the treatment that they have to give through their charitable programs, to like the little boy in Tanzania, go to the right patients, that we make sure that that patients are diagnosed properly, that they're followed up on the humanitarian aid programs. And the examples of the Tanzania patient is that often in a lot of these countries, patients have a long way to travel to maybe the big cities where the hospitals are. And what we can do is, has been done for this patient in Tanzania, is say, is there a local hospital where education can be given to that doctor to give the treatment so that the patient, it's more accessible to the patient, and they can actually continue to live their life and receive their treatment. So the Sanofi's charitable programme is open to countries all around the world. There is a criteria. If anybody is interested in learning more about that programme, Rosalind has my contact details. There's also the Takeda programme that the previous speaker mentioned, that works through direct relief, and that is open in countries like Ethiopia, Kenya, Botswana, and we are looking to try and roll that program out into other countries in Africa. It's also important, and this has been mentioned, that in order to get treatment, there has to be a genetic diagnosis through these programs. And those tests are often very challenging and very costly. And the companies will help, but if anybody wants additional support in looking for a test free of charge for their patients, then let Rosalind or Trudy know, and we will help to get that. Because as well as the companies offering free testing, we do have some laboratories around the world that are run by clinical experts in places like Brazil and Italy, who are also happy to do free testing for patients in countries where there are challenges. So just finally, we're very proud of the work that we do at the International Gaucher Alliance. We advocate all the time for patients. We want patients to have a voice. Now we have an impact report that is available on our website, and it clearly shows what we have achieved and what we are looking to achieve for our community going forward. So thank you very much. That's a very, very short presentation by me. Again, thank you for the opportunity. If anybody does have any questions about the work of the IGA or would like some support, please contact Rosalind and Trudy or visit our website. Thank you very much.
That was Tanya. Thank you so much, Tanya, for your presentation and the work that you do through IGA in supporting patients and also clinicians. Now, next up, we'll go into the question and answer. I see there's quite a bit of time that has passed, but I'll pick a few that was in the Q&A. I know they were answered, but for the benefit of everyone, I'll pick up, there was a question about how does the bond crisis manifest? Professor Hendricks, would you please maybe just answer that for everyone so that they can at least get some information?
Oh, absolutely, yes. So the classical way we see bone crises in our Gaucher patients are two things. Children we tend to find presenting with a painful hip, very simple, similar to a septic arthritis. What you tend to find is they get a really painful hip. They go to the orthopedic surgeons, they do an aspirate, they check and they say, oh, this is aseptic necrosis or infection. You usually find the CRPs are not elevated. None of the usual markers are elevated. So it's just this incredibly painful hip or lower back ache, quite severe. And these crises comes on quite, they usually have a niggle in the sense that patients said they start feeling them over a few days and then suddenly they just, it's so intense that they are really in so much pain they actually need opioids. So, but the two places are, most of them that I've seen has been hip or back. And as everybody who is a pediatrician will know, backache in a child is always a dangerous sign, so it needs to be fully investigated.
Thank you, Prof. Next up was a question on that the treatment was not very clear, and I believe Christine was referring to the presentation by Dr. Kandi. Please answer that.
Yeah, so I think Kandi's case was actually treated with enzyme replacement therapy, which is velaglucerase, which was done every 2 weeks on the patient she presented, and has shown a really nice effect, as we see in many of our patients. As Tanya has mentioned as well, there are multiple enzyme replacement therapies. It depends on what is licensed and agreed in each and every country, so they are different, and similarly for the substrate reductions. But the case that was there was an enzyme replacement therapy. But I do want to go back to my thing that everybody knows me well, I keep going back to. Please, please don't start off with we can't afford the treatment. Start off with, I have a patient who needs a problem. How do I solve it? What is the best I can do it? And then once I get to the point where I know I can't afford it, I start looking at what is the alternatives. But don't start off with, I don't. I usually say to people, you know, when I walk through the sports car section, I look at a Ferrari and I think I'd love one of those, but I know I can never afford it, but I can afford a Ford Ka. So you may have to adapt to what you can afford, but don't start off by saying, I'm never going to have a car because I can't afford a Ferrari.
Thank you for that, Professor Hendricks. And then finally, how available and what is the cost of velaglucerase? I might say my own things, but Professor, please take that.
Velaglucerase, yes. I think it depends on the country that you're in, and it also depends on the agreements which are in place. There are different things, and I would stay away from trying to quote the numbers because they are quite different in different parts of the countries. However, they are expensive. I think there is no need going away from that. And I have no idea what they will actually cost in that specific connotation. I know in South Africa, there are different deals in place, but it is an expensive treatment, and it also depends on which currency you're in and the exchange rate. So I think it's most probably, I'm not trying not to answer the question. It's an easy answer. They are very expensive treatments, but they are not the most expensive treatments. And I usually say to people, there are multiple other treatments which are more expensive, but because they don't work well, the patients die. These are especially cancer treatments, which are much more expensive, but because patients die, they don't have a lifetime cost. Our problem is our treatments makes patients better, so the lifetime cost becomes larger, but most countries can cope with that. And I've frequently said to people, your rare disease patients is a small budget impact, but you need to strike the deals with the different suppliers. And there are deals to be made, and these are more kind of health economics arguments and things. And there are some wonderful sessions on health economics and why this is important to get it done.
Okay. And finally, I'm not sure if this you can pick up, Professor Hendricks. It's a question from Dr. Diana Marangu regarding Candy's presentation. Of the 48 children tested, you mentioned 31 were negative. What were their eventual diagnoses, and what other differential diagnoses were entertained? I don't know if you can pick that up.
I can tell you a little bit because I know Candy and we've spoken about some of these cases. So actually, she's got a very high yield of positive tests, which is impressive. The other patients which has come in has mostly fallen out into the categories of the other lysosomal storage disorders, which is non-Gaucher. So there's been patients which has had cholesterol ester storage disease or Wolman's disease, although that's incorrect because Wolman is actually the infantile form of it, but that cholesterol ester storage disease is one of them. There were patients with Niemann-Pick disease in that group of patients. There were also patients with more local things. There were patients with leishmaniasis, if I'm not mistaken, in that group of patients as well. And ultimately, I think there's a small group of, I'm trying to think, and I don't want to lie here, but I suspect out of those one, there's about a third of them in which there wasn't a diagnosis and which the studies is ongoing. And that's another thing which we need to try and establish in Africa. We need to test that we know which conditions are common so we can increase our experience and we can slowly develop the diagnostics around that and then do complex diagnostics like whole exome sequencing and things like that to find the ones which are undiagnosed, and then we may actually find that actually there's more of them once we actually found the specific diagnosis. So I hopefully that answers you. So no, we don't have all the answers, and I may want to say something as a rare disease physician. When I see patients with a rare disease, I'm not talking Gaucher, I'm talking a rare disease in total, I tend to say to patients, I will make a diagnosis in half of my patients in 2 years' time. Take me 2 years to make a diagnosis in about half of the patients. Of the half that's left over, I will make another half of them a diagnosis over the next 5 years. And then 25% or a quarter, it will take me more than 10 years to find the diagnosis. And in some, I will hand them over to the person who comes after me, and I still haven't made the diagnosis. But that is not the argument. Let's find the ones we can and work on those we can't.
Okay. Thank you so much. At this point, I think we've come to our end, and I'd like to take it back to Agnes, but I'd like to appreciate all the presenters that availed their time, and Professor Hendricks for being here to answer the questions and for presenting again. For Dr. Muze, who wasn't here, but he was able to present her her case study. And finally, for Tanya also. And thank you so much for your time and for staying all this time. Thank you. Agnes?
Yes, thank you so very much for this wonderful presentation. Indeed, we've had many comments saying that it has been very informative and it is very timely at this particular point. Thanks for all the work that you're doing for Gaucher disease. And we welcome you again to even give us another presentation in coming time. So thank you, our listeners, for staying with us. We'll have another presentation tomorrow, as you can see, management of head injury, and even another one on Thursday, where we'll be talking about preparation for ostomy. So we welcome you to join us then. For this particular presentation, we'll have it up on the KNH website, but you can follow up with us at the knhresearch@gmail.com. So that to be able to send you the particular presentation, but we'll also have it up on the website and also have the recording out in time. So thank you very much, everyone. Do have a lovely afternoon. I'm Dr. Agnes Karingo Karume at KNH Medical Research. Thank you all.